Hey guys, today we're going to talk about basal cell carcinoma and in particular how it affects the geriatric population. So basal cell carcinoma, or BCC, is the most commonly diagnosed form of skin cancer, and it's especially prevalent in the elderly population due to the associated risk of cumulative sun exposure. BCC is a non-aggressive, slow-growing tumor, and in most cases does not metastasize, and making death due to BCC very rare. Despite BCC rarely being the cause of mortality, each year more than 100,000 patients are treated for BCC within their last year of life. So today we're looking at an article published in the Clinics in Dermatology journal named Aging and Treatment of Basal Cell Carcinoma. So the article assesses the impact of overdiagnosis of BCC and the implications of treatment for the elderly population. So when deciding whether a patient is a good candidate for BCC treatment, it's important for the provider to look at the patient's life expectancy and the tumor characteristics. And it's also important to know overall functional status of the patient and their lag time to benefit from treatment. So the concept of a lag time to benefit means that we have to not only assess how effective the treatment is, but also consider in relation to the patient's life expectancy. So overdiagnosis occurs when cancer screening identifies malignancies that would not have presented symptomatically during the patient's lifetime due to the slow progression of the disease or spontaneous regression. So when overdiagnosis occurs, it is likely that the patient would have died from other natural causes. So over the last decade, there have been a lot of advancements in screening and detection for BCC, especially among the geriatric population. However, the increase in detection rate of BCC has not resulted in an improvement in disease mortality. So the USPSTF gives BCC routine screening a grade I recommendation.
Okay, hi guys. I'm going to go over the summary of BCC treatments, effectiveness, benefits, and risks associated. So for BCC, there's a wide array of surgical and non-surgical treatments. Generally, surgical treatments are more frequently used due to their high cure rate and side effect profile. Surgical treatments include cutterage and electrodesiccation, or C&E, cryosurgery, standard excision, and the Mohs procedure. High-risk BCC are most commonly treated with the Mohs surgery as it provides a cure rate at an estimated 99% in areas with high functional capacity as well as cosmetically important to patients. Non-surgical treatments are typically reserved for high-risk tumors with poorly defined borders, aggressive histologic patterns, in difficult to treat areas, or in patients who cannot withstand or prefer not to undergo surgical intervention. Non-surgical treatment modalities include radiotherapy, topical agents such as fluorouracil, or targeted oral anti-neoplastic medications. Radiotherapy has a 5-year cure rate of 93 to 96%. For many geriatric patients, this is a good option as it is non-invasive, painless, and likely to preserve the functionality of uninvolved structures or neighboring organs. However, this treatment modality is considerably more expensive than other non-surgical options.
Hi everybody, I'm going to discuss the plan while treating BCC. The decision to treat BCC in geriatric population must be a shared decision between the patient and the provider. With patient-centered care in mind, the following question needs to be addressed. What is the patient's goal in treatment? What are the treatment options? What is the cost, duration, and risk versus benefit? Will the treatment likely help the patient during the expected lifetime? And now to the case study. A 75-year-old Caucasian male patient with past medical history of type 2 diabetes, hyperlipidemia, hypertension, prostate cancer, seizure disorder, major depressive disorder, and remission just received confirmation of positive BCC via biopsy results. There are 3 scattered lesions located along the right temple extending to the zygomatic arc. Each lesion is measuring 4 by 5 millimeter respectively with an erythematous base shining plaques with irregular rolled borders. Patient stated the lesions are non-painful and in no way affecting his ADLs. What treatment options will you offer to the patient knowing life expectancy is between 5 to 10 years? In geriatric primary care setting, what recommendations do you make for patients when performing routine care surveillance? And 3, what education would you give these patients to differentiate between BCC and melanoma? Thank you for watching.